Hi, everyone. Welcome to this meeting. I hope all of you can hear me. I have been asked to
Brendan, we've lost you. We seem to have lost connection. Let's give him a moment to come back on.
Sorry about that. Hi, everyone. I hope you can all hear me now. Sorry, there was a break in our transmission. I would like to just welcome you on behalf of Gastro Echo, which is hosted by the Gastro Foundation of South Africa. And this is an association with Project Echo of the University of New Mexico. Gastro Fellows is run every Monday from 16:30, and the chat will be open to questions. I really look forward to you offering us as many questions as you possibly can. We're going to be talking about fecal incontinence, a common problem, and one that I hope we will present in as familiar way as we possibly can. There will be case presentations, and around these case presentations, I hope discussion will commence. With no further ado, I would like to ask Nishlan Naidu to present his case presentation. Thank you very much.
Hi, good day. Sorry, let me just share my screen so that everyone can see. Okay. All right, so I'm Nishlan Naidu. I'm one of the colorectal fellows at WITS. And I'm going to be presenting to you one of the complex cases that had been encountered at Donald Gordon Hospital. This was a case of fecal incontinence post fistulotomy. So in terms of the background of this case, this was essentially a 40-year-old female that presented to us. She had previously been treated in 2015 for a perennial necrotizing fasciitis with an associated fistula in ano in the public sector. She had multiple debridements done. A diverting loop colostomy was done for her at a base hospital in Kalafong. And subsequent to that, she had a repair of a fistula and a flap done in 2019. And after which she had reversal of a stoma in 2020. In terms of her past medical history, she's a diabetic. She was poorly controlled at the time, and she's on oral agents. She's just had a previous Caesar ×1 and a VBAC or vaginal birth after cesarean in 2002. And she had this perineal surgery or multiple perineal surgeries between 2015 and 2020. She had a C-scope in 2020 as well, done in private, the exact details of which are unknown. And apart from that, she's a smoker with a 10-pack year history. So her presenting issue to us at Donald Gordon was that this patient had persistent fecal incontinence post her stoma reversal in 2020. And that was a primary pathology that she came to us with. She was otherwise clinically well. She examined well. Her abdomen was soft. But on a rectal exam, she had quite a large perineal defect with a considerable amount of scarring. We undertook a work. Her blood results at the time were unremarkable. Diabetes had improved quite substantially. She underwent a endoanal ultrasound and an MRI of the pelvis. And we then chose to manage her incontinence by offering her or diverting her again. So we did a transverse loop colostomy for her in October 2021, and an EUA with a pelvic floor reconstruction, a sphincteroplasty, and fasciocutaneous flap in February 2022. Now, the findings intraoperatively mirrored the findings that we found on MRI and on her endoanal ultrasound. So she had quite extensive scarring in the right perineum, and this had resulted in like a complete contracture of the space in which the ischial rectal fat would have existed. There was an injury to the puborectalis muscle on the right-hand side as well, with exposure of the levators. And there was concern at the time for the integrity of the common perineal nerve at this point, as there was an obvious vascularity that was devoid immediately beneath that previously incised edge of the levators. There was also a complete transection of the urogenital diaphragm with the transverse perineum that was freely mobile and detached from the perineal body in the midline. She also had transection of the external anal sphincter, so complete transection of the sphincter. The internal sphincter was fibrosed all the way up to the vaginal introitus, but there was no defect in that tissue of the vagina itself. So quite extensive damage to the perineal tissue and the urogenital diaphragm when we did that EUA for her. So that's why we proceeded at that time with this reconstruction, the sphincteroplasty, and fasciocutaneous or a lotus pleural flap. And subsequent to that, about a month or two later, she developed a wound breakdown, which we had to resuture in theater again. And subsequently, she healed. A couple of months later, we re-examined her. At this point, she had much improved anal tone. She also had a repeat endoanal ultrasound at the time and a porridge test, which she had passed. And after which she had a reversal of a loop colostomy in July 2022. So, we had essentially had this patient for about a year being followed up at Donald Gordon, but the issues spanned for her since 2015. She subsequently sent a follow-up email, and she was quite satisfied with the overall care that she had received. She had a full return to activities of daily living. She could function properly. She didn't have any confidence issues regarding a stoma anymore. There was no evidence of incontinence that she reported, with minimal soiling on her pads, and just an overall improvement in her mental well-being. However, the question is at this point, Will this patient develop incontinence at a later stage? And the answer is most likely yes, especially with the extensive damage done to urogenital diaphragm, external sphincter, and the puborectalis muscle. So this patient has been counseled about this, and as much as she is feeling well at this point, within a year or so, she may develop incontinence. And this will likely be approached with sacral nerve stimulation at a later stage. And again, this is quite a costly undertaking, and all not readily available in most centers. But we are doing quite a few at Donald Gordon and in our public sector as well now. So I just want to bring you to the anatomy of the urogenital diaphragm and the pelvic diaphragm. And if you look at picture B, you know, I'm not sure if you can see the orange line going across the external anal sphincter towards the deep perineal muscle. And that is essentially where the majority of her defect was located at that point. And, you know, this was quite a challenging undertaking surgically, especially dissecting out that anatomy. Something to consider as well when doing these repairs, when there is an extensive amount of fibrosis, usually you're expanding the area that you're dissecting. And when you're expanding that area you're dissecting, as much as it might be easier for you to see and fix the repair, you're leaving quite a large dead space as well, which can contribute to wound breakdown and perineal sepsis. So there's a couple of discussion points that I would like to bring into this, and especially in the context of South Africa and us being a third world country. You know, we know that the urogenital diaphragm is actually quite a complex area, especially within females. Anterior fistulas are notoriously difficult things to deal with as well within females. But apart from that, our incidence of perineal necrotizing fasciitis is actually quite high in our setting, whether that be due to our immunosuppressive states or poorly controlled diabetics, something that we see quite commonly. And, you know, the question arises from there is that once these patients have been debrided, how so should you be managing these patients going forward? And should these complex fistula disease be managed by general surgeons? Or should these patients be left indefinitely with a diverting stoma if they've sustained damage to their sphincters and the urogenital diaphragm after debridement of their perineal necrotizing fasciitis or complex fistula disease that have been managed with fistulotomy? And, you know, it's one of these difficult things to answer because, you know, we do have a public sector and we do have a private sector. And if this is being dealt with in a high volume institution, there's a lot that needs to be undertaken for these patients. There's a very high cost involved as well. And in private, if the resources and the centralization to high volume centers is available, then that's where they should be managed. But in the context of Africa and a resource limited setting, I think that the best way to approach this would probably be to offer the patient just a stoma indefinitely and appropriate counseling. The other thing to consider at this point is that we do see a lot of these patients being treated by general surgeons in private practice and in public practice. And in regards to training of proctology, it's something that we really need to look at. And it would be interesting to hear points from other centers as to how they would approach training in terms of management of fistula disease, both simple and complex, because I think that's something that really needs to be looked at, because as soon as you finish your exams, you're out in working as a general surgeon, and these are quite common problems that you will encounter, and these are not being managed as well as we thought they would be. Yeah, so I would like to hear some comments from everyone and Dr. Bebington himself. Thank you.
Thanks, Nishlin. That was great. Just a few points, just to expand on what Nishlin has said. You know, to reiterate, first of all, that notion that when there's been a lot of sepsis in the pelvis, if there's been necrotizing fasciitis, healing is by secondary intention in the long run. That results in scarring and fibrosis, and that scarring and fibrosis contracts inwards to the center of the wound. So as you come to dissect out these perineums, everything is stuck down in the center of a dense scar. And part of the procedure is excising that scar. As you excise that scar, so the structures bounce away from the center of the wound, and you get a better sense of what structures have been injured. I would say emphatically, if you are going to embark upon these complex reconstructions, it's a good idea to have a very good understanding of the pelvic floor anatomy before attempting to do so. And it is, I hope you will be able to see a presentation where there have been a number of approaches attending to the patient's continence. I think it's very reasonable that in the periphery and in people who do not necessarily want to address the pelvic floor pathology and do so with that understanding of anatomy, they perform a defunctioning loop colostomy. That's not giving up. That's doing the right thing under the circumstance. You need to help the patient in a way that is suitable to the patient and which is consummate with your own personal skill. And it may be then, once everything settles down, that you may look to get the patient transferred. The reason why I wanted to discuss this case particularly is the idea that sacral nerve stimulation may well be an important treatment in the future, but in a third world context, in a context of the developing world, I think it's not unreasonable, personally, to offer a primary repair of these lesions. Suffice to say that I think the initial repair that Nishlin had talked about had been unsuccessful because the actual anatomy hadn't been dissected out completely, and it hadn't completely been understood that there was a perineal body defect, that there was a defect in the urogenital diaphragm, as well as the puborectalis. And the complexity of that injury needed some time and effort to repair. Having said that, it's likely that this patient in the long run will have a further deterioration in her continence. And I think that Nishlin has brought to your attention that when treating patients like this, it is very, very, very important that you teach them all the conservative methods of gaining control. One that I can't but emphasize is the notion of small volume washouts. Now, what that is if you give the patient a Foley's catheter, a 60 ml syringe, and you tell them to put that into their anus every morning and inject 60 ml of warm water to wash out the bowel content. If you do that, what happens is that exercise tends to take over the patient's own bowel activity, and you can keep a patient clean and dry over a long period of time in that way. And all those conservative measures, the use of loperamide, the use of fibergel, the use of dietary manipulation, all of these are very important in the management of fecal incontinence. So if I could just encourage you to think of the multiple modalities that can be used to treat incontinence. As surgeons, think about what is appropriate for you to do and refer early. always look at the socioeconomic event that you are going to unleash when you do the surgery, and always consider the conservative management of fecal incontinence when managing these patients. Are there any questions? All right. Without any further ado, then I will ask James Pattinson, who is another of our fellows, to do his presentation.
Yeah. Hi, everyone. Let me see who I can pick on here. Okay. Can you see the slideshow, Karen?
Yes, I can.
Okay, excellent. So I'm presenting here from Theatre 7 at Donald Gordon. We're halfway through a pelvic exentration, so sorry, it's been a bit chaotic. This is a case that we discharged last week that we thought was interesting. It baffled us. So I'll go through it with you guys. So presenting complaint, it was an 83-year-old female. She came in with the complaint of fecal incontinence for 3 months. She said it was associated with diarrhea. She said it was spontaneous onset. It was associated with rectal bleeding occasionally. She, on further questionings, described a mixed urge and passive incontinence. She reported no weight loss. And then when we asked her how frequently she had the incontinence and if it changed her lifestyle, we calculated a St. Mark's score of 17, which is pretty high. So significantly affected her lifestyle. On further background medical history, she's HIV negative. She's hypertensive on one agent, had hypercholesterolemia. Surgical history, she had a hysterectomy before. We asked her why in 1975, and she wasn't sure, but she had a hysterectomy. She had a vaginectomy as well in 2012, vaginal prolapse done by gynecologist, and then hip replacement in 2018. She's a non-smoker, social drinker. Important, she has no obstetric history at all, has never been pregnant, and then has no significant family history as well. So when we examined her, systems were normal. Her abdomen was benign. She had a lower midline scar that was from the hysterectomy. On rectal exam, she had a decreased resting tone and also a weak squeeze, but appropriate muscle relaxation on simulated defecation. There was no palpable mass, no blood on the glove. She had an empty rectum, no stool, and then she had no rectocele palpable. So at this point, I wanted to ask one of the fellows, who can I pick on? Gert, are you there?
Yeah, I'm here. Thanks, James.
Yeah, what would you do as your first investigation? What are you worried about?
So I think just thinking conceptually, the alarming thing would be the bleeding that she has.
Yeah.
So that's a little bit disconcerting.
Are you worried about a malignancy?
So we would certainly consider a malignancy or a polyp in the age group, and then the other big consideration would be a grade 1 or 2 rectal prolapse. So I would probably go for a flexible sigmoidoscopy. I wouldn't subject it to a full-length colonoscopy necessarily.
Okay. Yeah, so we would. That's great. So I'm glad you answered how I wanted you to. We were thinking malignancy as well. So we actually did a full colonoscopy and a gastroscopy. On the gastroscopy, she had mild gastritis. She was H. pylori positive, so we gave her eradication. And then on colonoscopy, she had uncomplicated diverticulosis. We didn't find any polyps or any masses, no inflammation. We did, however, do random biopsies. The reason we did that is we wanted to exclude a microscopic colitis as a cause for diarrhea. That histology came back as negative. So what next would you do? Impor, are you there? So we've effectively excluded a malignancy in the colon at this point. She still has this incontinence associated with diarrhea. what would you think of him, Paul? We've lost him. Nishlin? Nishlin's just done an
Is there primary incontinence or not at this point? Be something to consider as well. So
yeah.
Did you then proceed with an endoanal ultrasound?
Yeah, so we're thinking maybe it's a sphincter injury or that's occurred occultly, or also she's got the diarrhea. Anyone that has significant diarrhea will be incontinent. So those were our two major hypotheses. So like you say, we did do an endoanal ultrasound that showed that there was no sphincter defect. Her sphincters were normal. And then maybe overflow incontinence. We did an abdominal x-ray, which was also normal, showed no dilated bowel, no obstruction. We wanted to work up for the diarrhea. So we did stool MCNS, we did C. diff, and we did a fecal colprotectin. They were all normal. So no joy in the investigations thus far. I don't know if I'm paused logged back on, but does anyone have any ideas at this point? Kat?
Yeah, I would go for a defecating or for a MRI defecogram if it's available. Otherwise, a normal defecogram.
Yeah, excellent. So we thought maybe it was some kind of prolapse that was causing the prolapse that might be causing the incontinence. So we gave her, as we normally do for pelvic floor problems, we gave initially conservative management, and then we followed up to see if that was successful. So our conservative management that we do, the mainstay is biofeedback, but then a number of other things as well. So dietary advice, stooling advice, we gave some fibrogel and some of the pyramide, and then suggested those low volume rectal washouts that Brendan was mentioning, and all of that was unsuccessful. So she still had incontinence after all of these measures. So like you say, we were thinking maybe a pelvic floor problem, so we did a defecogram. On the defecogram, it showed a mildly decreased sphincter tone, but no demonstrable prolapse and no other pathology. So we were still no joy on any of the investigations. So now we put it down to that we thought it was the diarrhea that was causing it. So we added to her above management, the conservative management, danzatron and acicol. Does anyone have any idea why we would add those? Kat, you've answered quickly so far, but
yeah. So the acicol would be to as an anti-inflammatory.
Yeah.
But the danzatron I'm not 100% sure on.
So yeah, specifically we're worried that it might be a diverticulosis associated colitis. So as you say, for the inflammation, we tried the acicol. And then the odanzatron, because we thought it might be a diarrhea subtype inflammatory irritable bowel syndrome. And odanzatron generally works for that. Unfortunately, after adding both of those things, she still was complaining of incontinence. So now we're starting to get into the realms of the obscure. Do you have any other suggestions now about further management?
Yeah, I would like to get a high definition rectal manometry to look at decreased rectal compliance and look at the anal inhibitory reflex.
Yeah,
a rectal anal inhibitory reflex.
Yeah, the squeeze reflex. We unfortunately don't have manometry, but we test with clinically. She did have a weak squeeze reflex. So yeah, we would do manometry if we had it available, as you say. We'll get to the high definition MRI defecogram later on. So now we decided what we were going to try is, because this was now a number of months down the line, we were going to try to do a sacral nerve stimulator. So what we do routinely with those is we send them away with a stool diary. There's an example of the one they use in the NHS there on the right. We have our own one here, but that's the one I pulled off the internet. So we did a stool diary for 3 weeks, and then we inserted the first phase sacral nerve stimulator as a test, and then repeated the stool diary for 3 weeks. And we were pleased to see that she actually did report an improvement. So it seemed like the sacral nerve stimulator was working. So we implanted it as a second phase. And then unfortunately, after 3 months, when she came back for follow-up, the incontinence was back, and she was complaining of neurological symptoms down the leg where she had had the hip replacement. So she asked for us to explant it. So we were all the way back to square one. So I'm sure none of you guys have any ideas, because we certainly didn't at this time, but every single intervention that we'd done by this point was futile. Thankfully, Dr. Bebington is able to do a pelvic floor ultrasound. I'm sure he'll tell you more about it just now. But on Valsalva, what he noticed now at the follow-up was that there was an anterior internal rectal prolapse on the pelvic floor ultrasound. So what we decided to do, like you said, Kat, we got that high definition MRI deficogram. That's not hers on the right, but it is one that shows pretty nicely what a rectal or internal rectal prolapse looks like. And it seemed like this actually all along was causing her symptoms. And the fact that we didn't pick it up on the initial deficogram shows that she had some progression of the disease, and we may not have picked it up at the first one. So what would you do now, knowing that she has a internal rectal prolapse?
Well, I would have a very long discussion with her.
Yeah, yeah, we did.
But
we did.
essentially, if she is willing to undertake the risk of an operation, and we know the morbidity and mortality even in elderly population of anterior ventral rectopexy is quite low. However, she had the prior vaginectomy, which is of concern, which will make the surgery more difficult and a little bit, I don't know, I always find it a little bit scary to go into that rectovaginal septum for benign disease, but I think anterior ventral mesh rectopexy is probably the best option for her if we're going to do surgical intervention.
Yeah, excellent. So the vaginectomy that I did previously was sort of, when we examined her, was fairly minimal, so we weren't too worried about that. And yeah, that's exactly what we did. All of these conservative measures had failed, so we did offer her surgery. We offered her as you say, a ventral mesh rectopexy. So just briefly, rectal intussusception, which was our final diagnosis. 75% of them will have fecal incontinence, as this patient did. Typically, they have a mixed incontinence. If you remember earlier on her presentation on inquiry, she described a mixed type of incontinence with urge and passive incontinence. What happens is that the prolapsed rectum causes internal sphincter stretch, and then that's an inappropriate trigger of the anorectal reflex, and that's what causes the incomplete rectal emptying and then the anal leakage. So as you said, we offered her a ventral mesh rectopexy. We happened to do this one open. Dr. Bebington has his own special technique, and she recovered well post-op, and we're still waiting to see if that was successful. And hopefully, after all this time and all these measures and all these investigations, this is finally successful. So I'm sure Brendan might want to comment now. Thanks, Kat. You answered perfectly.
Thanks, everyone. Thanks, James. Are there any questions before we go any further? Everybody? Anybody? Okay. Everybody? Any questions? The wonderful world of fecal incontinence.
Can Dr. Bebington, Gert van der Merwe here again. Hi. Yeah, thanks so much for your time and effort. Really appreciate it. And James, thanks for your presentation as well. And Nish, could I ask you, I think, in our setting, probably the most common cause is obstetric injury still.
Yes.
Could I just ask you to briefly touch on that and sort of give a general approach, again, accepting that we'd start with the conservative measures first, but yeah. Okay,
so remember, with obstetric injuries, you're going to meet them in a number of contexts. First of all, there is the acute injury. So the gynaes call you, sorry, there's a delivery that's just happened, and we think that there's disruption of the sphincters. In that circumstance, the recommendation is to treat them primarily and not to do a defunctioning colostomy with that. I would encourage you to go look up what they do in the UK and the work of Sultan, who has pioneered the concept of primary repair and has started training with the program of OASI. And in that, all layers are closed one after the other. After debridement, with a reasonable debridement, I would encourage you not to cut away too much tissue, be very sparing with your debridement, and do a primary anastomosis in layers end to end with PDS. And in that way, the vast majority of cases will be fine and will have no problem. The second context in which you will meet them is when they have had their injury and they come to you scarred, fibrosed, and they're looking for a repair. I'm not going to give my own personal preference. I'm going to give you an understanding of what is considered appropriate internationally. But internationally, there are two approaches. One, there are some people, particularly in Europe, who would say, don't even bother with a primary repair, because 1 year later, a good 75% of those patients will have a deterioration in fecal incontinence, making your efforts at primary repair secondary repair as virtually redundant. For that reason, what they would say is go on to sacral nerve stimulation. I must say, in a developing world context, I have an issue with that. And I would say that there is still a place for a repair of the defect. And again, I will tell you that you should use the same principle as I told you with the scarred perineum as a consequence of the sepsis. Chop away the scar, get to that normal tissue, have an understanding of what the sphincter structures are, and do your repair in layers. All layers in interrupted PDS except the external sphincter, which would be double-breasted and sutured with 2-O-proline is usually how we do it. There's some controversy. Some people would say that PDS is okay and end-to-end is okay in that setting. Tradition has been more along the lines of repairing it in that way. Again, there is no necessity to do a colostomy in that circumstance. And it's often good, particularly if there has been a large defect, to consider local flaps of one form or another when doing this surgical repair. And it is only then those patients that do not respond to that sort of treatment that I would then consider the possibility of sacral nerve stimulation. My own personal experience is that the vast majority of patients, if you treat them with the conservative measures for fecal incontinence and you do that primary repair, then you don't really need to go on to offer the patient sacral nerve stimulation. However, that is the option to take. I would also say this, I'll say it again. I remember when I first came to Wits Donald Gordon Medical Center, there was an old surgeon who had run colorectal services in private in Joburg for many, many years. He had tried many different methods to attend to his patients with fecal incontinence. And he said to me, young man, I think you should just give them colostomies. And yes, you know, in the long run, a colostomy is not what a patient wants, but a well-constructed colostomy can change a patient's life. And I wouldn't say just ignore that possibility. Gert, I hope that gives you some idea of the approach.
No, thank you very much. Just a comment. I've been treating a couple of these injuries. especially with the cloacal defects that we have after grade 4, they all get referred to as late.
Yeah.
And obviously, I don't have long-term success rates, but I've been using the flaps that's described in the Corman's textbook, and so far my short-term outcomes look okay, both in terms of continence and the flaps. I can't remember the name of the technique, but it's essentially just lifting perineal flaps from the gluteal area on both sides.
Yeah, you can do bilateral VY advancement flaps.
Yeah, that's it.
You could do a Z plasty. The one that I like using is a lotus petal flap, which is a rotation flap. I would encourage you to look those up and see, but if you're going to be embarking upon this type of surgery, those are flaps that are very useful. Another useful flap, and I would encourage you to look it up, is the Marsh's flap. That in the smaller defects and smaller low defects is a very useful flap to use.
Thank you very much. Appreciate it.
It's a pleasure. Thank you, Gert. Are there any other questions? Okay, we're finishing early. Is there anything else that anybody would like to say? Well, it remains for me to thank the speakers for all that they have done. I really appreciate their contribution to this meeting. I hope it's been of value. I've certainly enjoyed it. I'd just like to thank Echo University of New Mexico and the Echo India team for the support. Please give us feedback from in your chat. And remember that the recording of this meeting will be available at the Gastro Foundation website. And I'd like to thank the Gastro Foundation as well for their contribution. The next meeting, sorry, let me, I just need to, the next meeting will be on the 29th of August 2022 at 4:30 as usual. And the topic on this occasion will be gastric cancer, and the presenter will be Lucienne Ferndale from UCT. Many thanks for your participation. I really appreciate it. Cheers, everyone.
Thanks very much then. Thanks all for joining. See you next week. Bye.
Cheers.